All right, so we'll make a start. It's 1 o'clock on the dot. Again, welcome everyone to this month's CPD session. Again, for those of you who don't know me, I'm Dr. Joyce Ramos, and I'm an exercise physiologist and a lecturer and course coordinator here at Flinders University. And of course, your facilitator for all things CPD for the CHAP program. So today's session is focused on the 6th module of the CATCH web system, is focused on medication education. So today we are very lucky to have two speakers. First, we have Ms. Jing as our guest speaker, followed by our service of the month from the ICCNet CATCH phone service, which will be presented by Cathy King. So firstly, we have Ms. Jing. So Jing is a senior cardiology pharmacist currently working at Flinders Medical Center. So Jing aims to provide patient-centered care and best possible medication management within the health sector. So Jing is a highly motivated and enthusiastic pharmacist who enjoys working in a multidisciplinary team to promote quality use of medicines and strive for new challenges. Previously, Jing has worked in various clinical units, other hospitals, as well as the community setting. She's now applying her knowledge and experience as a specialist pharmacist responsible for the implementation of pharmacy services that optimizes pharmaceutical care for cardiac patients. In addition, she is also mentoring and providing training, education, and professional direction to other pharmacists, students, and health professionals. So Jing will be presenting a talk titled Discharge Medication Education for Rural Cardiac Rehabilitation Nursing. So Jing, please take it away.
Thank you for the introduction. Hello, everyone. So we'll just jump right into the topic. Basically, my purpose of my talk today is to introduce to you what we do as a pharmacist in the hospital, and hopefully it helps you get a good picture and you'll be able to continue the patient's care when they get discharged post-hospital. So the cardiology pharmacy service in Flinders Medical Center currently is mainly an inpatient service. We mainly have patients in the 2 wards, CCU and 6DC. So CCU has about 20 beds and 6DC is 16 beds. These are all cardiac monitored beds. So usually patients are placed on these wards, but if they have passed the acute stage, they can be placed in other areas of the hospital, but be mindful that these other beds won't be cardiac monitored. So sometimes we do have outliers during the COVID times, especially. We have 3 main people working. We have a senior pharmacist, which is myself. I'm job sharing with another pharmacist named Cathy, who is amazing, has lots of experience as well. We mainly do heart failure patients, acute heart failure patients, heart transplant patients, and also general cardiology outpatient queries. We also have a full-time rotational pharmacist who mainly looking after your patient, which is the acute coronary care, ACS, or arrhythmia patient, ARR. And because the workload is a lot for 2 people, so we usually have a pharmacy technician, but she's only here 0.7 FTE, which is not a full-time. So that's like the general idea of our service. So what do we do? On a typical day, we look after the patients, we go on ward rounds, we look at their medication history on the mission so that during their hospital stay, we can do medication review and make sure we recommend the evidence-based therapy. And then during ward rounds, we give our recommendations if we can, and then ultimately helping the patients to discharge home. During the discharge process, we do have a few things that we do. I'm not sure if you have seen them before. So we have medication lists that we provide our patients, and obviously medication education. We also provide CMI. These are consumer medication information. Usually manufacturers do make them, leaflet, they will provide a lot of extra information that the patient doesn't need to know. So we actually provide our own type of information leaflet, a bit more simple, a little bit more easy for patients to understand what they need to know, like the basic things, how to take them, what is this actually used for in their heart condition, and also what type of side effects you might experience, and also a phone line so that they can call us back if they has any queries. Usually we will try to facilitate about 1 month supply of medication from discharge day, just to get the patient time, get back to their feet, go and see their normal GP and get back to where they're from. Usually if they are already on a Webster pack, we can help them discharge with changes to the Webster pack, or even with patients who, after having this admission, couldn't actually manage their medicines, we can start the Webster Pack service from discharge day. However, it is a bit more difficult with rural patients because not sure how near a pharmacy can be if they actually visit the same pharmacy, but it can be done. And last but not least, out of hours on a day-to-day basis, we also do cardiac rehab education. This is different from what I'm doing right now. We run this service every 3 to 4 weekly. It's at the private hospital where we actually, part of our session, through the rehab program as an outpatient setting, that we go through medicines with patients more in small groups, about 5 to 10 people each session. So this is one of the example of information leaflet that we've done in-house. So these are updated every 2 years, and all obviously with new information or changes in practice, we can update them ad hoc basis as well. This is an example of like a medication list. So as you can see, it's quite clear. We got the patient's detail at the top, and usually the medication name and strength, and we also put it in a different color, like a red color, to say this is a new medicine, so that the patient understands what's the medication's name, some brand name they recognize the medicines from, why they use this medication, and then what time of the day, quite clearly written there, which is to prompt them what they need to take every day. So I'll focus mainly on the ACS service, which is our acute coronary syndrome care service. Basically, it's a very high turnover service where we had about 40 patients discharged just last 2 weeks. I did a quick calculation. Due to only one pharmacist doing this service, we only managed to capture about 60% of these patients. Sometimes pharmacists do miss these patients due to various reasons. So it could be a weekend discharge. I'll come back to this later. I'll put a star there. Maybe the patient done an after hours discharge, because our service is quite specific, 8:45 to 5 p.m. Sometimes when the patient go for the angiogram or do for any tests, they come back, the doctor decided they're safe enough to go home. Sometimes we just unable to capture these patients. And because of hospital bed being so limited, sometimes we do have public patients located physically in a different hospital, a private bed. So pharmacists can't really go over and do the discharge there. Sometimes when patient has no changes in their medication, so they might have a stress test done, everything looks okay, they got discharged home for outpatient follow-up, then I think these types of patients, the pharmacists kind of prioritize and not see them sometimes. Unfortunately, being in the cardiac service, we do have non-cardiac related chest pains. These patients usually are at low risk, which we don't see as well. And out of the 10% of the patients that we miss, there are about 5 patients that probably needed education, but we are unable to capture them. So I guess in this point of view, being in the cardiac rehab program in future in the outpatient setting, it's quite important for nurses to understand sometimes these patients don't get the best discharge education. So I'll jump straight into the main types of education we give. I'm doing a very typical ACS presentation when they usually will go home with like an antiplatelet. So for example, aspirin, ticagrelor, clopidogrel, these are the example medication. And we will talk about why are they used, how long to use it for, how to take these medicines with the patient. We also will discuss bleeding risk quite importantly, because for our typical patient who get a heart attack and goes home, they're usually not on a lot of medication, some not even being sick at all, and they got this event and had to go home with medicines. We do have to go through everything to make sure that they understand medicines have benefits and risks. So we will talk about risk of bleeding, like black tarry stools, sometimes red color, coughing up blood, or even like coffee ground vomit or nose bleeding. They have to actually talk to the doctor, because when the benefit and risk is not there anymore, they should be actually reviewing, seeing if this is the treatment they have to continue. We also advise them if they're on antiplatelets, if they have a fall or trauma, if they have surgery, they just need to let the doctors know. So medicines can be withheld if they can before surgery, or even like when they do a procedure, the surgeons know what to look out for. As a pharmacist, we also talk about practical tips. So for example, can you take this medicine with all your other heart medicines? The answer is usually yes, or if you take it with or without food. And we always try to advise patients to be very compliant with their medication. And usually compliance are shown for the first, I say, 2 to 6 months since discharge. But I do see patients represent again in future, maybe a few years down the line, but that's more on patients' behavior. So education is quite important as we are placing on discharge. They are ready to go home. They need to know what and how to look after themselves. Another thing that patients usually go home on is cholesterol lowering medications. So some of the example medication is your statins, like atorvastatin, rosuvastatin. These are more common because it's very safe, lots of evidence used behind them. We talk about cholesterol targets with patients. We don't talk too much about lifestyle or diet, because that's not our main goal. We will touch on them, saying how they have to change, but obviously we'll talk to them how we aim the LDLs at what level and how often you should be doing your cholesterol level with your GP, just to make sure everything is normal. Talk about side effects again. We'll talk about muscle pain, muscle fatigue, how to recognize them, because some symptoms like muscle pain, they don't appear right after they take the medicine. So it can happen maybe 2 weeks down the road. And these are what we call like a delayed effect for these patients. One misconception a lot of patients represent would be talking about, my cholesterol levels is fine, why should I be taking it? From a pharmacy point of view, we always talk about how it ensures the plaque does not rupture, holding up all the coronary arteries. So we talk about benefits beyond just cholesterol lowering for these medicines, and also tell the patient expected duration would be lifelong for most of them, and compliance is quite important. So cholesterol tablets does have a lot of bad publicity or lots of myth around, and we try to answer them ad hoc as well. So if patients go home, settled back in their life, they notice their cousin or whoever, friend, takes the same medicine and they read something online, they can always call us back if they're unable to reach their GP, and then we can talk about how true what they've learned on Dr. Google might have said. I'll move on to the third group of medicines. If the patient can tolerate, most of them would be recommended to use ACE inhibitors, or another group called a sartan. These are blood pressure medications, but it's also helpful for the heart to prevent remodeling, and also depending on what cardiac event they have, it is a class 1 recommendations in the European or American guidelines. So it's quite important that your patient is on these types of medicines, depending on the indication and how they can be tolerated, basically. So one main thing that I noticed patient unable to tolerate the ACE inhibitors would be dizziness or even coughing. 1 in 10 people actually experience coughing with ACE inhibitors. It's more like a dry cough. It's usually not happen immediately when they take the medicine. It can happen a few months down the track. So patients recognizing symptoms, patient doesn't have a lung disease background, able to, talk to the doctor and able to pinpoint some of these medicines if they are started within the last 6 months. Fortunately enough, due to medicines advancement, so the started group of medicines are quite similar to ACE inhibitors, but they have less likely to cause the same effect, coughing. Like previously, with my cholesterol tablet, we'll talk about doing blood tests every 6 months if they can. Sometimes with ACE inhibitors, we'll try to monitor their kidney function and potassium levels, especially at the start. So the first week when they first go home, usually we will request for like a blood test to follow up with a GP, just to make sure everything is fine and this medicine is not causing any harm. And talk about the duration. It's usually lifelong as well for these patients. And how do we titrate the dose? So this is something we can also help doctors with. So for example, if the patient's saying, I'm taking a 5 milligram tablet, I'm already halving them. My doctor wants to reduce the dose again to a quarter. It's too small. How do I do that? So as a pharmacist, we know what dose and what strengths available in the market. We can actually tell them, by the way, these medicines comes in like 2 milligrams. You can request that from a different prescription so that you don't have to quarter these tablets, which can be quite tricky for elderly patients. And compliance again that we want to talk about. This may not be quite common, but if the patient's blood pressure is holding up, we usually try to introduce beta blockers as well to these patients. So beta blocker is another blood pressure tablet. It helps to control the rate of the beating of the heart. Depending on which beta blocker you're choosing, there are different type of evidence. There's more than 10 types of beta blockers in the market at the moment. I'll throw out some names. So like atenolol, metoprolol, bisoprolol, nebivolol. Even metoprolol, we have slow acting and immediate release. Actually, all of them are targeted for different types of heart event. So for example, for our ACS group of patients, you will see metoprolol used quite often or atenolol, and usually first-class evidence to reduce remodeling and also prevent angina, so all your chest pains. It can lower blood pressure, it can cause dizziness, they should go away within the week. They can cause fatigue, but these symptoms are usually more watch and see how they go. And if the patient after a week or two still complains of the similar symptoms, it's time to see a GP and do changes to the medicine. One thing that we note as well, drugs don't just interact with drugs. Sometimes if they have existing condition like asthma, then we have running a risk of asthma exacerbation. So what I mean by that, if we know this patient has asthma, we'll choose a beta blocker that is more selective to the heart, not as selective to the lungs, so that they don't have that risk there. Beta blocker is another medication that we try to put patients on as long as they can, and also ask them to be as compliant as possible. As you know, by controlling the rate, sometimes if you skip a few doses, patients will notice the initial side effects will come back again, like the dizziness, the fatigue. So being compliant is also a very good way to prevent patients from, getting those side effects as well. Rebound effects, to be more precise. For patients who have reduced ejection fraction, or what we say, going towards the heart failure area, and it's heart failure due to a myocardial infarction. So there is good studies where patients can be also put on eplenorone. Eplenorone is a medication that acts like a diuretic or a fluid tablet, not like your typical furosemide, but it's actually helpful for the heart to prevent, readmission, cardiac death. lots of studies been done in this. So now we are recommending it as first line, but it's cleared by the kidney, so it's quite important. Just like the ACE inhibitors or the statins, we will monitor the renal function and potassium at the same time. The durations usually as long as they can tolerate that. Usually, if a patient being put on so many medication, they get too dizzy at one stage, we will look at how strong evidence things are and also advise your doctors or nurses to which one to take out first if they're getting too dizzy, so that they are still getting the best care that the patient has. And usually recommending to take this in the morning just to prevent, waking up at night, going to the toilet and things like that, which can improve their compliance. This one's probably very familiar for a lot of people here, glycerol trinitrate, or what we call the pill in the pocket. It also exists in different forms. It could be in a bottle, a red spray. Usually all the tablet or the spray is also done under the tongue. It's usually to help patients when they have chest pains, they need more oxygen and blood pumped through the heart. So we use glycerol trinitrate to open or dilate the vessels, the arteries in the heart, buying us time so that blood can flow through, and call 000 and come and help. I'm not sure if everyone knows the steps on how to use it. I'll just quickly go through them. So with what we call glycerol trinitrate or GTN spray, we ask them to prime the bottle, check expiry date before using each time, and make sure patient's sitting down, just because of the very sudden dizziness and headache effect that can come on when they use it. Give it a good shake. Prime it 5 times in the air. When they're ready, just 1 spray under the tongue. If they feel like they're missing it, use another spray. That's all right. 1 to 2 sprays is usually okay. And look at the clock. Make sure after 5 minutes, the symptoms are gone. If they're not, repeat the actions again. Prime it. Use 1 spray under the tongue. After 2 lots of this, if the patient's still having this chest pain, it's time to call 000. I know sometimes when we say, oh, call the ambulance, it's quite straightforward, but we have to remember for the patients, for a layman, sometimes they don't know what number to call. So I always will highlight what to do it, and also give them like the information leaflet papers that I talked earlier. It has like a flow diagram quite easily for the patients to learn from. Sometimes patients will be calling out, asking, why is my medicine not working? When I have chest pain, I've used twice, nothing's working. There are a few things with these medicines. So storage, quite important. Expiry date, as I talked about. Exposure to light, exposure to heat. These can make this medicine become not effective anymore and will be quite useless to the patient when they need it. I briefly talked about headache, dizziness, and flushing earlier. This comes on really quickly. When you use it, within 5 minutes, these effects do come on just because of the dilation, how the medicines work. But then it only lasts about 15-20 minutes. So if the patient do experience that, if their chest pains is resolved, they're on a tablet, they can spit out the tablet if they want. But if they using the spray, obviously they can't do anything, but the symptoms reassure them 15-20 minutes, it should go away. So it acts fast, but it doesn't stay in the body that long either. One good thing I always tell my patients before they leave is also tell them how to access this medicine. Like all medicines, if you got a prescription, you go to a pharmacy, you get it filled. Sometimes in emergency setting, you cleaning out medicine cupboard, you notice, oh, I haven't used this in a long time. I need it. I can't see my doctor. Always tell your patients these medicines are emergency medicines, so it's available in local pharmacies. They just have to make sure to reach over the counter, speak to a pharmacist so they can record supply when they do that. So a prescription is not needed, but a prescription can help them save money down in the future. And very important to always carry the medicines with the patient. There are new studies, so new evidence to show this group of medicines, SGLT2 inhibitors. So I'm not sure if everyone in this talk was here last year. We talked about how this is a pending thing. Watch out, new evidence, new medicines use. It's now registered and also PBS subsidized to be used for our patients who have reduce ejection fraction. There are more new evidence shown in preserved ejection fraction, which is if your ejection fraction is more than 50%. But these are not subsidized yet. So you can still access this medicine, but it'll be more expensive to the patients if they do. Previously, this medication, this is the group name, SGLT2 inhibitors. So the actual drug name would be your dapagliflozin or Forxiga, or your empagliflozin or Jardiance. So these two medicines previously was approved for diabetes, now approved for heart failure use, and in future we are looking more evidence using in patients with renal problems, renal kidney problems, or even like preserved heart failure patients. So just a little mechanism of action. We actually don't really know how this helps with the heart. We know how it works in diabetes. So it promotes glucose into your kidneys, you pee this glucose out. There are some speculation. They did say maybe it's because better control in diabetes, better heart condition. But we are finding more evidence to show that people on these medicines come back hospital less hospital admissions, less death within the 5 years, and less worsening of their cardiac symptoms. So it's actually a really good drug. There is a few things they need to know. Like all diabetes medication, there are what we call like a sick day or fasting day or surgery day. We have to stop this medicine because they can cause this condition called ketoacidosis. And it only happens when the patient's still taking SGLT2 inhibitors when they are sick or if they are fasting. And one very common infection side effect is genital infections. As I mentioned earlier, this medicine works by pulling sugar into the kidneys and then peeing it out. So if there's more sugar in your urine, more highly chance to get like thrush or UTI and symptoms like that. So that comes into a conclusion of all the medicines that's commonly prescribed and good evidence for a patient who comes in with a heart attack. And I'm just wanting to talk a little bit about like COVID-19 impact. So because of COVID-19, we have more funding. There is more pharmacists. So sometimes in the earlier slide, I talk about weekend pharmacists. We do have a trial for the last 3 to 4 months that we have a pharmacist on a weekend now that sees discharges. So we are capturing a bit more patients there, but we are not having an exclusive cardiac pharmacist. This pharmacist is shared between other medical wards. So we usually only able to see high-risk patients and depending on how busy their workload is on the weekend. So it is good that we have that service so that patients who get discharged on the weekend and at high risk are not missing out on any of these services. But unfortunately, it is a lot of support for just one pharmacist working on the weekend, covering all other medical areas. And also with the increased workforce, sometimes we get pharmacists who are not cardiac trained, which is going to be quite difficult because we are all about evidence-based practice. And it's quite specialized. Sometimes new pharmacists are not trained enough and they won't know. So if you always in doubt, always ask questions because there is no silly questions. Always ask so that we can, if we can answer, we'll try to answer. If we can guide you to like the specialist pharmacists who can do it. During COVID-19, we have limited patient, family, or visitor support. So some patients doesn't look after their own medicine. So that's quite hard as a pharmacist when we're trying to do medication history. So lots of phone calls, luckily we can do that. But for patients who have like family barriers or live alone or don't speak English, that's quite difficult. And we do notice that during the COVID-19 times. But fortunately enough, we talked about how now Flinders is now by Sunrise. It's an electronic system where pharmacists can work from home, access files, and able to ask for specialist advice more easily. with COVID-19, everyone is more busier than ever, lots of restriction. If the patient comes in, have a heart attack and caught COVID, how do they access medicine? So it's just lots of barriers when they get discharged at that point in time. Also harder to communicate with, people who looked after the patient. And I talked about the cardiac rehab service during COVID-19, the peak period. We actually stopped this service. We were going to do it online, but because it's hard to set it up for the patients at home, so it's something that unfortunately was withheld for at least 2 years with that. But everything's back and up and running now, so that's good news. So I guess to end my talk today, I just want to ask, is there anything as pharmacists that you think that we can support your service as well? What do you think that we are currently doing or you are doing and what we can do better? Is there any opportunities that we can capture in a hospital before they go into community?
Thank you so much for that wonderful presentation, Jing. So I guess, is there anyone from the audience that would like to respond to these questions before we move on?
I have Sarah on the line. Yeah. Hi, Sarah.
Hi, thank you for an amazing talk. That was really, really good. I was thinking about what are the most common issues that you notice in patients when they are readmitted. So you've done a brilliant job at educating them by the bedside and sending them home with their drugs, and then they come back maybe 30, 60 days later. What are the most common misadventures that you find in this group of patients after discharge and readmission?
So that's actually a very good question. I would say there are actually two very common ones when we see patients readmit. Number one is, I think patients do get a bit shy. When they get on discharge, they're shy asking questions and so much information. I'm not the only one who will be discharge counseling these patients. So nurses, physio, doctors, everyone have their own little thing input in there, and they get really overwhelmed. So sometimes they will come back and you notice that they are not understanding the discharge medicines actually that well. So I think the cardiac rehab program is good for that group of patients because they get like your weekly slow input, and it's quite useful for these patients. That's why I talked about the CMIs and also medication lists. Sometimes patients lost them. That's why they couldn't, do anything with them. But we do keep a database with that. So if you see this type of patients, let us know. We can reprint this list if this is what they want. And we notice patients. The other type of admission would be just resistant to change. Basically, they're living in denial. Sometimes they're even still smoking and things like that. So I think every opportunity is there. We have to really just be patient and try to talk to them and see how receptive they are, so that they really truly understand what is used and good for them. Yeah.
Okay, are there any other burning questions before we move on? I do have a question for you, Jing, at the end. Okay, so we'll move on. So the next part of this session is the service of the month. And this will be presented by Catherine King. So let me just bring up my slide again. Okay. All right. So Cathy is a Catch Clinical Service Associate and Coordinator at ICCNet, based in Bedford, Adelaide, South Australia. She previously worked at Royal Adelaide Hospital Cardiac Unit for over 16 years. She then moved here about 7 years ago when the program expanded from the Southeast to statewide. She has also been involved in the expansion of the program with only 2 nurses working initially in her service and now up to 7. So without further ado, I give you Cathy Jing. Please take it away, Cathy.
Thank you. I'm just sort of looking at the actual staffing numbers we have here. Like I said, it's got grown significantly. It was initially just at the southeast, now it's the whole state. So I'll just introduce, because we've had a lot of changes in our staff over the last 5 or 6 years. And if you can see that screen, the one on the left is Caitlin, and you'll get to know her, Caitlin Wandell. So she's the central referral point in a sense. So she does all the referrals that come in, sends them all out to the country. So she's processing up to 100. The next girl is, we've got 2 admin, but we've only got 1.5 really, because she comes a couple of days a week. Then we've got Celeste, she's our dietitian. So she'll come in just Thursdays, and spends about an hour with each patient and goes through all their diet with them. So unfortunately, she can't get to all of our patients, but the ones that have the need, we'll put them on with her. Then we've got Tracy Barry. So Tracy has been working, Tracy, 30 years. At the Royal Adelaide Hospital. Yeah, she's got extensive experience. She's been working in coronary care. She's done lots with heart failure. She's been involved with the Heart Foundation. She's an ambassador, and got a wealth of experience to bring here in ACSs predominantly as well. So that's lovely. And next to her is Sandra Story. So Sandra has come from England about 7 years ago, 10 years ago now. 11. So Sandra worked in coronary care in the NHS and then has come over, and that 11 years she's been working in the lab. So it's really good to have someone that's worked in the cath lab, to go through those arteries a little bit better with us. So that's great. And she actually also does the home monitoring. I'm not sure if people know about the home monitoring. We have another program that runs alongside this with ICCNet that does chronic disease home management. Then we've got Jess, who sadly just left us a few other day, probably a week ago. And then we've got myself. I'm not going to go on about myself.
Awesome.
No. And then we've got... I'm not going to Sherry Astley. So Sherry has been in coronary care for a number of years, a lot of years as well. But she's recently come to us. We're pretty lucky, from the Flinders Private Hospital cardiac rehab. So she's got a lot of experience in that. So that's fantastic. And then we've got Kate Elliott. So Kate has come from the Royal Adelaide as well, and I suppose her focus is atrial fibrillation, because we cover that quite a lot of atrial fibrillation now. And then we've got Gemma, who's unfortunately left with us. So not on that picture is our new clinical lead, is Louise McIver. So everyone will get to know her. So she's come from a lot of experience in post bypass surgery. And then she's gone over to Sydney and worked with the transplant team. So she's had a lot of years with that, and her expertise is in that as well as heart failure. So we're really excited to have Louise with us, because heart failure is a lot of our patients are in that predicament. And along with that, we also have a pharmacist, Sue. She'll work on a Friday, and she's invaluable as well, because a lot of those drugs, when we don't know the interactions as well as she does, obviously. And we would like to get two pharmacists, but we just got the one. We also have a social worker, and the social worker comes in once a fortnight, and he'll cover things like, he can do a little bit of counselling, but he predominantly does referrals for people that, haven't got money or anything social work, which has been great. What's the other allied health?
EP, but we've not got one.
EP, yeah. So EP's been our biggest. We're still waiting for an exercise physiologist. They're quite hard to get. So we're hoping to look at maybe getting a physiotherapist, because I think that's probably where we're failing in a little bit. I don't like that word failing, but lacking in the post-surgical. Would be nice to have someone that can actually speak to the people and go through what you do post-surgery, as opposed to just us talking. We get a visual. So we're working on that space to get a physiotherapist on board. But Sherry's also got some experience with that. And is that all of us? Yes, I think that's all of us. So the whole idea of the catch was to basically catch people that were missed on the referral. So probably about 8 years ago, they started picking these people up under a code. So they got automatically referred. The private hospital does it differently. They'll fax us through with their referral. But predominantly it's come through as a code from all the major hospitals. And then Caitlin will go through it and ascertain whether they need to be referred to their, the local face-to-face sites, or if they live 50 kilometres or more, they'll get referred to telephone program. So that's basically at the bottom, average of 32 or 7 catch telephones per week. So there's a lot of referrals coming through. I think that's all. So our program is pretty much like most of them. It's a 7-week program with 4 calls with a nurse, and if we can get them all in, we tend to end up doing about 6, 3 or 4 calls with the allied health. We've also got Health Direct, which we're working on. We had a few trials of it last year, but a lot of us were working at home. It was becoming a little bit tricky, but we're hoping to have our first call to be a Health Direct call where we can go through the cardiovascular system and disease process, or the anatomy. Yeah. So we cover a lot of range of conditions, and it's sort of grown over the years. So predominantly our focus is ACS, and the ACS, we try and push they get all those extra calls, but we often have all these other ones as well. So heart failure, AF, arrhythmias, tachycardia, vasospasm, SCAD and others. And we do get that variety, pacemakers. We also get pacemakers and lots of AV ablations and things like that. So the advantage of it is, I suppose we're reaching the people that wouldn't otherwise be able to go to these sites. We're getting people within 7 to 14 days after hospital discharge. So it's sort of a reassuring thing that they get when they get home. They really appreciate just a call to say, how are you going? And we can tailor it a little bit individually. We also have this GP hybrid program, which we've been doing for some years. And the idea is that we'll refer people to have a GP management plan. And if they're eligible for one, and if the GP does them. And the idea is that we're building a relationship with the doctors, but also continuity. After we finish their 7 weeks, they can actually go on and be looked after in that way. Okay, and the numbers, pretty much, that's how many people have been referred, how many commenced and how many completed. So I think telephone, probably it's easier to reach people because you just ring them. They don't have to go anywhere. They can come in, just answer the phone. So I think our completion rates, because if they miss a class, we could just ring them the next day. So it's a little bit easier in that way. Is that all, do you think? Okay. So pretty much that first one's fun. The other thing that we do, and we've referred a few patients, is we have this thing called My Health Pocket. I'm not sure if anyone's heard about that out there. So it's a program for chronic disease management for country people, and their doctor will select a few patients, and we've got about 65 or 70 on the program at the moment. They're not anything to do with catch, but we can refer them. So they'll do all their vitals, depending on their chronic disease, and it will come through to us, and Sandra and myself and Kate will do the monitoring of it and look at it and see if it's out of range and ascertain whether it needs escalation or, and the hope is that we see a trend over the years of, or over the months, sorry, of what's happening. So we can actually look at our catch patients and say, actually, at the end of their 7-week program, their blood pressure still isn't controlled, or their heart failure is not controlled. We can suggest they get put on this program. Have we got any more? Okay, COVID impacts. Probably with our program, there was really minimal impact in saying, because we can work from out of office, we don't have to see patients. Possibly, like everyone, there was a strong need to quickly get tech savvy, and we had to work from home initially because we were in crowded offices where you couldn't distance, and it is difficult to talk with a face mask on all day. So a lot of us did go home for about, nearly a year, I think. Was it?
Overall,
yeah.
Oh.
And it actually worked for some and not others, but I certainly loved it. I think it's just an individual thing, but you could get up and not be interrupted, do your work, ring people out of hours. It was quite good. So it's a flexible work environment that really suited a lot of us. All back in the office now, and learning to be back in the office, I suppose. So as far as any other impacts, we got a lot of patients that you notice more anxious, more so in the country, and I think because they didn't have exposure to more so now to COVID, like we've got used to it. So we're still speaking to people that aren't leaving their home because they're scared of COVID, but they might not live in a farm or something. So it's interesting. We've grown, to know that possibly we're going to get it and possibly it's around the corner, but they haven't got to that point yet. So there's a lot of anxiety. A lot of people over the time were talking about immunisation. That was quite tricky. Should we get it? Should we not get it? And they were particularly over the Christmas break, when there was limited GPs, which you understand in the community. We were relied on a lot. It was quite difficult. There was one patient I sent down in rapid AF, another one with a pleural effusion. So over the phone, hearing this problem and not having someone to call can be a bit challenging. Luckily, it's settled. I'm not sure why, but it's settled, and we can move on. So current projects that we have, quite a few, don't we? A few going. We've just done one with just this morning with the Heart Foundation. So we're going to be doing support calls for them because they've lost their funding. So we'll be doing support calls, just one initial support call, and they'll be they're referring on them to their program. We've also got the chat, obviously, as you know, with Robin, and there's lots of involved in that. And I think that's all. Yeah, are there any more slides? No.
And that's it, Cathy. Thank you very much for that comprehensive insight to your team and the services that you provide. I don't have a question for you, Cathy. I think that was very comprehensive, but I do have a comment in terms of that exercise physiology role. I do have someone in mind that I could refer. Okay, so I'll be in touch. And are there any questions for Jing?
Cathy, I often hear the patch nurses talking about the way patients love the anonymity of being on the phone.
Yeah.
And do you think that is actually a benefit? Like those who don't go to rehab will actually feel safer, more comfortable, and do you feel that they tell you more secrets than they normally would in the clinic or at rehab?
Oh, absolutely, Robin. They'll tell us everything.
Oh.
And sometimes things you don't really want to hear. But it probably is a benefit because they, they are anonymous, and it is a very different relationship that we've all had to learn to manage this different relationship on the telephone. And in fact, I did a face to the health director a couple of times, and it just freaked me out. It was very different. They got shy, I got shy. So it's an interesting. I think if I had cardiac rehab, touch wood, I'd like to be anonymous.
Well, I think we all learned from Zoom how terrifying it can be to be Zooming on a bad hair day, and then everyone can see you. So you know, I guess that's the first thing. And then we've seen cats all over the keyboard, and we've seen kids in the background, and so there's stuff you don't really want to bring to work. So I understand.
Yeah.
The second question was to connect you to Rui, our pharmacist today. The VCC must be amazing support for dealing with medication side effects and medication management. Do you agree? Do you think the My Health Pocket, telemonitoring stuff, do you think that is a really
with
great
pharmacy
additional support for medication management and side effects?
Oh, well, I'm not so sure about that. I'm not sure, because it's more of a chronic disease management. The GP is doing, so we don't really want to take over that part, I suppose. And it's more what you say, someone's insulin or their sugars were too high over the few months that they're on the program. Some of them are on for years. I don't think we basically, Sandra sends a letter every week, an email to all the clinics, and says this is happening, their trends are going down, their blood pressure's going down, or their sugars are usually quite high, and that alerts the GP to make some change.
Okay, so you do support, sure, that's great, that's wonderful. Thank you very much.
Wonderful. Are there any other questions for our speakers today? All right, I do have one for you, Jing. Are you still there?
Yes, I'm here. Sorry.
Okay, fantastic. So for those referred to cardiac rehabilitation, where exercise is such a big component, at Discharge, do you also give them advice of the potential or education on the potential impact of medication or exercise, medication on exercise and vice versa?
Usually, I would say that's less in what we would comment, because we really leave that to the expertise of like a few exercise physiologists to tell them what's the best. And most patients who recently had a cardiac event, when they get discharged home, they are recommended to slowly ease back into the lifestyle. I do have patients who would be like exercise enthusiasts, and they will be like, oh, is this gonna affect if I do this in future? Maybe they're talking about 6 months or a year later kind of thing. Then yes, we would talk about, like, for example, what are they doing? What type of sports they're doing? For example, if they're more prone to injuries, so being on an antiplatelet, we have to really tell them what to do. Your first aiding, so that they know what to do in first hand. And a lot of exercise people likes to take supplements as well. So that really comes to our role, where if we notice they have certain trends, so if they like exercising, we will be more inquisitive. I think when we ask, like, do you take magnesium, you take calcium, all these other little things, and then we will talk. It's quite important in future, if you take anything new, you come back to us or your GP. And also make sure, I have lots of instances where we saw some patients taking some proteins and things like that, where we don't have evidence. We will ask them to withhold, and then the doctor can do like reintroduction challenges. So restart and observe any side effects, and then go on from there. So yeah, I think minimal, but yeah, there are a few things that we do talk about with them.
Wonderful, thank you, Jing. So if there aren't any other questions for our speakers, we'll end the session. I just want to remind you that we do have our chat project showcase coming up on Friday, the 17th of June from 2 to 5 p.m. at Samri Auditorium or via Zoom. So we would greatly appreciate if most of you can come along. And we also have our next CHAP CPD program for July on the 13th. And we will be focusing on module 5, tobacco cessation and alcohol reduction. And our special guest for this session is Professor Jacqueline Bowden. So again, thank you once again for all the speakers for today and for the audience. Thank you. Have a good day.
Thank you.